global training and educational purposes only. Candela Corporation and its affiliates make no representations regarding federal, state, local laws or regulations that might apply to use and operation of this device. For this reason, please review your country's current indication for use as provided by the respective regulatory agency. This content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Treatment considerations are under the discretion of the qualified licensed healthcare professional. Individual healing times, discomfort, treatment results, and satisfaction can vary. Please discuss these, as well as risks and benefits of this procedure with your qualified healthcare professional to determine whether this procedure is appropriate for you. Benign pigmented lesions should be evaluated, diagnosed, and cleared for laser treatment by a dermatologist or appropriately trained physician. Incorrect diagnosis of pigmented lesions can lead to delay in diagnosis or misdiagnosis of skin cancer, including malignant melanoma. Malignant transformation of pigmented lesions can occur, and laser treatment of these lesions can impede proper follow-up and diagnosis. With that, I'm very pleased to introduce Dr. Konika Schallen, VP of Clinical Operations and Medical Director at Candela, and owner of the MedSpot, the Center for Modern Aesthetic Medicine in Jacksonville, Florida.
Getting started with Meghan, I'd like to introduce Meghan Murphy, RN BSN, to you all. I've had the pleasure of working with Meghan for, I think, 8 or 9 years now, and Meghan has a great deal of experience. Before she came to me or came to us at Candela, she'd already been in practice in California, working in medical spas and also with plastic surgery, and has been working with many of the devices prior to coming to Candela. And then together we were able to do many interesting things together, including establish the center, the Candela Institute for Excellence, which is our Candela clinic. And Meghan's been able to work with the research and development teams and help get a lot of these products launched in their current state. So really excited to listen to Meghan. She's a very talented clinician and very entertaining as well. So we'll have a fun hour together. And thank you so much, Meghan, for doing this tonight.
Thank you, Dr. Schallen. Okay, so we're going to talk about the GMPP tonight, and it is a great system, and it is something that I would use daily in my private practice. So the beauty of the GMPP is that it has the increased power supply, so it is able to deliver more clinically efficient energies. It also can offer higher repetition rates. There is the addition of the larger spot size now, and so what's kind of interesting about the larger spot size is that it's able to penetrate deeper into tissue. So although the larger spot size, sometimes the fluences offered are a little bit less aggressive than the smaller spot sizes, you do find, because of the bigger spot size, it does give you a deeper depth of penetration, which has been very interesting to see clinically. And then it does have the shorter pulse duration. So now you can use the 2 millisecond pulse duration on fine hair. And in some cases, if it's a lighter Fitzpatrick skin type 1 through 3 that has kind of that resistant light pigment, you can try to use the short pulse duration on some of those isolated individual lesions if you need to. So the GMPP has 2 wavelengths. It has the 755 nanometers and the 1064 nanometers. Your 755 nanometer wavelength is indicated for the treatment of laser hair reduction, benign pigmented lesions, and vascular lesions. One thing to remember is if you're using your 755 nanometer on vascular lesions, you do want to think about the fact that the 755 is highly absorbed by melanin. So when you're using it on vascular lesions, you want to be a little bit careful with the melanin absorption. So just kind of remember that when you're using it. I tend to not use 755 nanometers unless I'm unable to clear something with the 1064 nanometer, and always only in the lighter Fitzpatrick skin types. And then you have your 1064 nanometer wavelength, which is going to be less absorbed by melanin, a little bit more absorbed by water. And so you can use this in laser hair reduction, all skin types, vascular lesions, the facial treatment, diffuse redness, and onychomycosis, which we'll get into a little bit later. So I always like to go over the fundamentals of laser first, because if you understand those, I do think you're able to provide more effective treatments. So the first thing you want to think about is the wavelength. The wavelength is going to be the light that's offered by the device. Then you have your fluence, then you have your spot size, then you have your pulse width, or also referred to as your pulse duration, and then you have your cooling. Now, cooling is a parameter that actually, Dr. Schallen, you have taught me that really is something that you want to consider. It really is a fifth parameter, so you do have to pay attention to it when you're using it. And DCD is, I mean, you and I play with that a little bit, I would say. And it is a great addition to the system, and it does offer an ease of use, but it is something that you do have to understand a little bit when you're doing the treatments.
Yeah, I'd agree. I mean, cooling is definitely a fifth parameter, and you can, once you understand it, it really can work for you to make sure you're protecting the epidermis, and able to safely treat all year round and treat all skin types, but also still get to your target as long as you can manipulate it. So we'll get to that a little bit when we talk about cooling, I'm sure.
Yeah, exactly. So here's your basic chromophores of laser. This is from Dr. Wu, and I love this diagram. So the easiest way to think about this is, where is the target and where does it lay in the skin? If you're treating pigment, the easiest pigment to treat is going to be your discrete, isolated, individual benign pigmented lesions. They've been seen by a dermatologist, so you know that they are typically residing within the epidermis. Those are going to be the easiest to treat, and typically really the only ones indicated with GentleMax Pro Plus, unless you're an advanced modality, which is another talk. So when you're thinking about your pigment, it's going to lay more superficially in the tissue. So that's just something to consider. When you're talking about your blood vessels, those are going to typically reside in the dermis. Your redder vessels are going to be more superficial. Your bluer vessels are going to lay deeper in the tissue. And those typically will be in the dermis, sometimes in the subcutaneous tissue, but typically in the dermis. And then your water, we're made up of 70% water, right? So the water is going to be homogeneous throughout your tissue. So like, for example, the 1064 nanometers, because the 1064 nanometers is absorbed by water, you're able to get kind of that collagen stimulation because you're heating up the temperature of the skin. And so when you think about a water absorbing wavelength, those are typically used to treat collagen and can, in some cases, have an effect on elastic fibers or elastin, which is kind of an interesting topic, but just some food for thought. So your water wavelengths are typically going to be used for wrinkle reduction. It's also what we use for the onychomycosis. Do you have anything you want to add, Dr. Schallen? And sorry, I hope that you're okay that I'm asking questions while you're on the call.
No, that's great. Yeah. We should have the conversation. No, I agree with you. I think that our Nd:YAG, we're talking about Nd:YAG here specifically, and its primary chromophore in this case, when we're talking about water, helps us with wrinkle reduction, and that's primarily what we're talking about. It has a different mechanism for onychomycosis, but in this case, definitely impacts collagen through its heating up water and bulk heating. Mm-hmm.
Okay, so the first parameter everyone should consider, really is the most important parameter, is your wavelength. So you need to make sure that the wavelength you're selecting is based upon the patient's skin type and the desired target. So, you know, for your darker Fitzpatrick skin types, you're always going to have a less risk adverse treatment if you use the 1064 nanometers. And then the other thing you want to think about is, what is my target? Is it going to be blood, water, or melanin? We can get into the onychomycosis later a little bit, but basically, what is the actual target? And is the wavelength I'm using going to be absorbed by the intended target? Now, the part of this that gets really important is when you're talking about skin types. So the longer the wavelength, when we're talking about wavelengths between 400 and 1064 nanometers of light, the deeper the depth of penetration. So your 1064 nanometer wavelength is going to typically be absorbed deeper or go into the tissue a little bit deeper than your 755 nanometers. The other thing to note is the longer the wavelength, the less absorbed by melanin. So your 1064 nanometer is going to be less absorbed by melanin. So what that means is the 1064 is, as you're pulsing it over the tissue, it does not get absorbed as soon as it hits the epidermis and hits that melanin, okay? It's able to get a little bit deeper into tissue and bypass some of that melanin. Your 755, however, as soon as you're pulsing it, starts to get absorbed by the melanin within the epidermis. So you have to be you really have to think that out when you're treating. If you use your 750, you really don't want to ever use your 755 nanometers on a fits 6 and really never fits 5. So just something to note. So when you're selecting your treatment parameters, this is something that you have to think about, okay? So this is a graph that really helped me when I was starting. So with laser hair removal, the desired target is the melanin within the hair follicle. So if you look at this graph here, the melanin is going to be the lighter purple curve. So you can see here at 755 nanometers, let's just say that's right there. As you go further down, your wavelengths become less absorbed by melanin, which is why you're able to use the 1064 on all skin types. Now, with 1064 nanometer facial treatments and onychomycosis, but kind of a little bit of a different mechanism, you're typically targeting the water within the tissue. So through light absorption within water, we are able to induce tissue stimulation. Dr. Schallen, do you want to get into the onychomycosis MOA?
Sure, and we may get into that a little bit more later, but fungal treatment of the fungus itself is also based on heat that's targeting the fungus directly and creating cellular damage. And there may be some chromophore components too. There's been some studies done that show that there's actually color chromophore in some of the variety of different fungal elements or different fungi, depending on what's being treated. So it may be selective photothermolysis directly to a chromophore, as well as just heat that causes cellular damage to the fungus.
Interesting. Who knew fungus had color? But here we are. So with vascular and or diffuse redness treatments, you are targeting the oxyhemoglobin or the deoxyhemoglobin within the vessels. We get into that after. So that's just kind of your individual chromophores. But again, when you're looking at the curve, you can see here, your oxyhemoglobin is going to be your darker purple, whereas your deoxyhemoglobin is going to be the gray. And although at 755 nanometers, you can see that it will be absorbed by the intended target, your melanin absorption is increasingly absorbed with this wavelength. So just some food for thought there. When you're using the 755 on vascular lesions, you definitely want to make sure it's on a lighter Fitzpatrick skin type. And you just want to remember that it is a little bit of an advanced modalities in some regards. Okay, so let's talk about spot size. So when you're delivering the laser light into the tissue, the laser light beam is comprised of photons, which are these light carrying mechanisms. And so these photons are your packets of light. And so the intended target has to absorb the photons that you deliver. Once those photons are absorbed, this causes the temperature within the target to increase to a destructive temperature. So when we're talking about the GentleMax Pro Plus versus like our Peak Away, or even really, well, yeah, just let's say Peak Away for now, we're really relying on heat as the main mechanism of action. And so you're using the heat to be absorbed by the target and kind of have an effect on that target. Now with smaller spot sizes, there is an increased probability of photon scattering outside the laser beam. So Dr. Schallen, you actually taught me this, but if you've ever driven on the road, like the highways in California, they're like 5 lanes and your car, not that anyone should drive like this, but your car has the ability to move through the lanes and stay on the pavement. If anyone's been driving in Ireland before, it's a very different story. And the car only has a little bit of room on the asphalt before it can move, into the grass typically. So that's kind of the same thing with your laser beam with your spot size. So deeper, larger spot sizes, less scatter equals a deeper depth of penetration. Smaller spot sizes, more scatter. So that's going to give you a shallower depth of penetration. So that becomes important when we're talking about the intended target. If we're talking about pigment that's truly epidermal in nature, our spots, we could get away with using a smaller spot size. But if we're talking about hair follicles specifically on the back, let's say, you definitely need a bigger spot size because especially on the back, those hair follicles reside really deeply into tissue.
Yeah, you're absolutely right. I mean, spot sizes do two things for us, and you're right. The larger the spot size, in general, the deeper that the photons can reach. And then there's effective fluence, which you described with the highway example, and that's about keeping photons all in the area that of the target before they're off out scattering. So that large spot size makes such a big difference. And you found when we were treating with the 26 millimeter spot size, we were getting much faster results and a larger percentage of results and reduction in hair counts with the same fluence than say 18 millimeters because our fluence was more effective and we also had a slightly larger, slightly higher depth of penetration.
Correct. Okay, so again, this is just a diagram showing kind of where the targets are intended. So water is located everywhere, typically with the exception of the stratum corneum and hair shafts. And then your melanin is most predominantly located within the epidermis. It is created via melanocytes located at the DEJ. And so when you're treating benign pigmented lesions, epidermal lesions will typically respond best. And you can kind of identify an epidermal lesion. I really like to use the Visia and kind of look on either the porphyrin setting or the benign pigmented lesion setting on there, which is the brown spot setting. So when you look at that, a truly epidermal brown spot will typically have very clear defined borders. You're not really going to see that masking of pigment. It is really a good idea. Like I have worked with Dr. Schallen actually, to evaluate our patients. And then even with her, sometimes I know that we've referred patients to derm if we have a question. And so it's always a good idea to really have the patient, and I really do ask my patients to have yearly derm skin checks. It just is something that's, to me, a good sound clinical practice. So just kind of ensure that what you're treating is actually an epidermal lesion, because if it's really not an epidermal lesion, you're really not typically going to see the result that you want to. And also, you just want to make sure that you understand what you're treating. Do you have anything to add to that, Dr. Schallen?
No, you're absolutely right. I mean, it's so important. I mean, in my private practice too, before treating blanketly across the chest or the face, we always make sure that they've had their skin check by their dermatologist, and that's very important. So you're right.
Yeah. Okay, so melanin is also going to be located within the hair shaft as well as in some areas of the follicles. Sometimes what we're talking about with melanin incontinence is basically when the dermal epidermal junction has been disrupted in some way. So for me, unfortunately, I have melasma, so my DEJ is, not healed, sadly. And so my pigment actually does leak down into the dermis a little bit, which gives me kind of this mask-like appearance. So you just really want to assess that when you're looking at the client, or obviously send them to derm and have them assess. So your blood is located within the blood vessels of tissue, which typically reside in the dermis. The ones we can successfully treat are in the dermis. For anything red in nature, as I said earlier, these are typically located a little bit more superficially. For anything blue in nature, those are going to be located deeper within the dermis. Okay, so pulse duration. So pulse duration is a very important parameter that I did learn to the extent when I was using the V-beam, because the V-beam, we have to play with the pulse duration quite a bit. So think of your pulse duration as how long the laser is on the tissue for, or how long the tissue is exposed to the laser pulse. This is selected based off of the thermal relaxation time of the target. So the thermal relaxation time of your target is how long it takes for the intended target to lose approximately 50% of the delivered thermal energy. Okay, so your thermal relaxation time is how long it takes for your intended target to lose 50% of the delivered thermal energy, or how long does it take for the target once it heats up to cool back down by 50%. Now, one thing about Candela that even when I've worked with competitor systems, we always get our pulse durations right. Like every device we have has the ability to vary the pulse durations, and we are really always within a great ability to deliver effective results because we have so many pulse durations available on all of our systems. So just something to note, that's a really important parameter that I do think people, not that they don't understand, but that maybe we're not using to the full effect. So for example, there's a question in the chat that says, the labia is terribly resistant. Do you have any tips? So first I'd have to ask, what Fitzpatrick skin type is that patient? What pulse duration are you using? Now, the one thing with the labia that Dr. Schallen, I'm sure you can attest to this, is oftentimes it is a little bit darker pigmented than other areas. So that is kind of a fine balance. If it's a darker pigment, you will still want to stick to your longer pulse durations.
Oh, absolutely. And the nice thing about the GMPP is you can treat the lighter portions of the skin with the 755. And if you need to switch to the 1064, it's super easy to switch. And that's what you should be doing for the darker skin, including some of the area of the labia if it's darker.
And then just a question, like for me personally, for the years that I did laser hair, the labia never fully, do you find that it fully goes to the 80%, or are you looking more at 70 or 60%?
No, I think a lot of people get really great clearance, but there are some tips and tricks, and you're right. I mean, I think that when the hair is thicker, it's important to go ahead and lengthen the pulse duration a bit so that you really are getting the larger target, its full exposure to the laser energy during a longer period of time. And then as your hair gets finer, then you would decrease the pulse width. And even for the darker skin types, that's okay. Sometimes too, and this is what I would call advanced, because we don't typically recommend this, but you can go ahead and treat with one wavelength to cool the area, and then treat with a second wavelength. And sometimes that also helps, because remember, there's a slightly different mechanism of action with the way the alexandrite is targeting the bulb and the bulge, and the way that the 1064 nanometer wavelength is working to reduce hair. So it may be that, when you're doing all of these things at once, provided that the skin is cooled and you're using the right wavelengths and the right pulse durations, you tend to get a pretty good clearance. Now, that said, any area of the body that is very hormonally influenced, like the face, like the labia, like the men's shoulders, for example, those are really resistant sometimes, and maybe there's not this clearance that doesn't need touch-ups. You may need an annual touch-up here and there, but.
Yeah, like I always used to tell my clients for face hair, we're going to be friends, not clients here, because I'm going to see you for your 6 to 8 sessions spaced at 4 to 6 to 8 week intervals. And then typically they would come in usually quarterly for some, especially if I think there's like some kind of hormonal component, maybe. Okay, so ideally your pulse duration should be less than or equal to the TRT of the intended target. So I believe there's a graph in this PowerPoint. If not, it's in like every single PowerPoint we ever make with Candela. So I'm sure if you go to our portal, you'll be able to find one. But just remember, with shorter pulse durations, this can be a more aggressive energy delivery. There is some thought that the TRT of the epidermis is 3 to 10 milliseconds. So if you're trying to bypass the melanin in the epidermis, some people feel as though 10 milliseconds or longer is a little bit safer. So just remember, when you're using shorter pulse durations, well, this should be your rule of thumb always, but when you're using shorter pulse durations, I usually always decrease my fluence by about 20%. Sometimes I'll go down even more than that and just test spot until I see my desired endpoint. Oh, I said the next bullet point. And then, and we already talked about the heat diffusing out of the epidermis. So, okay. So here's my next slide about the TRT. So you can see here, I really liked this graph because it does show you the TRT of the target. Now, I'll be honest, when you're doing a lot of rosacea, or if you're doing a lot of diffuse redness, I still believe the best way to treat that is going to be with either your V-beam or your Nordless. You can get nice results with the 1064 nanometers on our system. And so what most people do is they'll do the 1064 painting treatment, which is when you use the drop down screen, you use those settings there. And the reason that you will see an improvement is because the pulse duration on that is typically around 0.45 or 0.5. So you are shorter than the intended target. Now, where you're kind of have to shift your focus. So like right now, I have a lot of flushing going on. I don't know why, but it's hot in here. So when we're talking about patients that present like I do, where I have this flush effect going on, I have a lot of little capillaries in my skin that push blood to the surface of the skin. So in order to effectively treat those, I need to use a shorter pulse duration. When we're talking about linear telangiectasias, like on people's chins or their legs, that's where you need to start to think about the longer pulse durations. One thing about individual telangiectasias and blood in general is that with the 1064 nanometer in specifics, when you pulse the first pulse, you change the oxyhemoglobin or the deoxyhemoglobin to methemoglobin, and then every pulse you do thereafter is a lot more absorbed. So you want to skip, and this is in the PowerPoint later, but just be very respectful with the 1064 nanometer wavelength when you're doing anything where you're targeting blood. It's just it can be a very strong energy delivery. So just make sure that you feel really confident on that when you start to do that. But when you're doing linear vessels, so vessels you can see, you typically want to use longer pulse durations, higher fluences. Now, textural irregularities, when you're doing your collagen stimulation treatments, those are going to be the water absorbing. And really, I always just use the pulse duration that gives me the intended fluence. So any pulse duration can work on this because it's just going to heat the tissue. So just something to think about with that. Heating water can lead to beneficial effects, and you'll see that later in the PowerPoint. And then, actually, Dr. Schallen, I feel like you're kind of in the same boat as I am with this next topic, but with your brown spots, you typically want to be at 3 milliseconds or shorter. There are some, like PicoWay does a great job on pigment, and that uses an ultra short pulse duration. So just something to think about. But I do see very nice clearance with the GentleMax Pro on benign pigmented lesions when I'm at 3 milliseconds. Do you agree?
Yeah, absolutely. I mean, I think that as the big thing is that you have to be, this is entirely thermal. So you have to be cognizant of your other skin types or your darker skin types. And so that's where the picosecond lasers are so much, I think, safer across the board, because more of their mechanism of action is photomechanical as opposed to photothermal. So then you don't get so much inflammation, or you don't have the melanin that's targeted in the darker skin types to the extent that it is in a 3 millisecond pulse duration. But right. Otherwise, 3 milliseconds works great. I know Dr. Jill Weibel taught us the technique of treating large areas like the chest, for example, for pigmentation with 18 millimeter spot and 2 hertz and painting across the chest until there's some darkening of the lesions, and that works really well also with a shorter pulse duration and a high rep rate. But 3 milliseconds on individual lesions, individual epidermal benign lesions works very well. Just protect the melanin around them.
Right. And then hair removal, again, melanin and blood of the hair follicles. Now, this is a little interesting. So technically speaking, the TRT of those is 20 to 30 milliseconds. I really don't. Do you ever go to 20 milliseconds? No.
For hair removal?
Yeah.
I don't, but rarely for PFB, for example, right? At that point, sometimes we do, but there are cases, and we do see it in Europe. They tend to do 20 to 30 milliseconds. In the Middle East, sometimes when you have darker skin types, or in the summertime, you are going to be a bit safer on darker skin types with longer pulse duration, but it's really not following the rules of selective photothermolysis, which really work very well with 3 milliseconds and below.
Right. Okay.
We've got a couple of questions. I know we've got a lot to talk about here, but we can pause and answer a few of these, I think.
Sure.
There's a question about, how you set your fluences, and this is probably a good intro into what you're about to talk about. There's no set recipe. I think the question is, is it true that you just increase your fluence every 2 joules at every treatment? And I think, Meg, talk about what you typically do at session 1 versus session 2, session 3 versus session 2. It's not a blanket recipe. You kind of look at the skin response as well. You look at whether the patient's been in the sun in the interim, all those things, right?
Yeah. Okay, so typically I'm usually using the 18 millimeter spot size, or larger now with the GMPP. So typically in my earlier days, I would use the drop down menu. So I always would just use the drop down menu and kind of go based off of that. When I first start, if it's their very first session and they're new and I'm doing laser hair removal, I always typically start with the drop down, which typically is going to give you the 10 millisecond pulse duration or potentially the 3 millisecond pulse duration. And I'll increase my fluence like 1 or 2 times. And then if I don't see the endpoint, then I'll consider decreasing my fluence, decreasing my pulse duration, and then starting again. And then, so I'll decrease the pulse duration, decrease the fluence, pulse. Now, the big thing with you're doing laser hair removal, for example, is you need to hear, sorry, this just reminds me of something our colleague used to say, a snap and a tingle. The patient needs to report that they feel a rubber band snap. The patient reports a rubber band snap, you smell the smell of success, as most people would call that. And then you kind of want to look, ideally, you really do get perifollicular erythema and edema. I used to not think that was necessary when I was treating the darker Fitzpatrick skin tapes with the 1064 nanometers, but I actually do see that now, and I like that response.
Except for, I think it is, you see a really brisk response with the 755, especially in the lighter skin types, that you have to be very, very discerning to see in the darker skin type with 1064. And it is possible that you don't want to treat to the level where you're looking for, a large amount of erythema in a darker Fitzpatrick. Wouldn't you agree?
Yeah, and especially not in the size of the laser beam. So if you're looking and you're treating the darker Fitzpatrick and you see what I call footprints, which is, so if I pulse here and there's a perfect round circle, that usually means my fluence is off. I really think a lot of times too, it means they've had recent sun.
Yeah, well, and there's a question here about whether clinical endpoint is about seeing this perifollicular edema or whether it's seeing the hair fly out of the follicle or remove itself from. And I think that your endpoint really is about the edema. It's about the inflammation that's gone around the follicle, not the mechanical effect of the disruption of the hair follicle.
Right. Okay, so I'm just going to try to get through some of these. So we have the Candela system. This is from one of our users. We have the Candela system, and sometimes when we treat Middle Eastern and Indian clients, face or upper arms, I think what they're talking about is they're seeing some paradoxical hypertrichosis. So for those patients, okay, so when you're treating, and I did used to see this sometimes in San Diego, what I understand now from reading through the literature on paradoxical hypertrichosis, which is basically when you have unintended hair growth in other areas, or you may have increased some growth in other areas. One thing to think about is your fluence could be a little bit too low. You want to cool around the area. Like if I'm treating a woman that has fine hair like here, I usually cool around the area so that the heat doesn't diffuse and is not high enough to actually kill the follicle, but low enough to actually stimulate some hair growth. And then I typically use the shorter pulse durations on fine hair, so around 2 milliseconds. What do you feel, Dr. Schallen?
Absolutely. I mean, the paradoxical hypertrichosis is really because of the adjacent areas that get subtherapeutic heat delivery, and you get some stimulation, some paradoxical stimulation. So you're right. You pre-cool the areas adjacent to keep that from happening. You treat properly in the areas that you really do want to treat. So you want to try not to be too subtherapeutic, and the finer the hair, adhering to the principles of selective photothermolysis, the shorter the pulse duration. And in our studies that we did with 3 milliseconds versus 2 milliseconds, we found that after 4 sessions and out to a 6-month follow-up, we had about a 9 to 10% improvement in hair counts over the 3 millisecond pulse duration in fine hair, and that's after 4 treatments. So still early in a lot of this work, but we do have some data that supports 2 milliseconds in fine hair over 3 milliseconds.
Perfect. Okay, so people are asking what I use to cool. I typically just use like a cool compress or ice packs.
Yep.
Okay, and then, oh, Bronwyn's on. Hi, Bronwyn. Don't you feel that with the larger spot sizes, Bronwyn's just saying sometimes with the larger spot sizes, she doesn't always see the PFEs that she likes to see. I do see that typically, but when I don't see that, especially on my lighter Fitzpatrick, I'll just decrease the spot size. And there is some thought, there is some thought in the literature, and we have to speed up here, but there is some thought that as the follicle gets finer, it's maybe not as deep within tissue. Do you agree with that? What are your thoughts on that?
I don't think that the depth of the follicle changes, but you have less target and less heat around around that target, so you have less edema because there's going to be a little bit less inflammation because there's less target. So, but I think Bronwyn's right, and this is a change between the GMPP and the GMP. When we had a 26 millimeter on the earlier version, you didn't have necessarily the effluence that you needed at that particular spot size, but with 20% increased fluence with the GMPP, you're right, Megan, in your experience now with the larger spot sizes, you are seeing that endpoint, and that endpoint is important. So if you're not seeing the endpoint, especially in the lighter skin types where you should clearly see it, then you drop your spot size in order to increase your fluence.
Right. Thank you. Okay, so some of these questions, I'm very grateful that you're engaging. I really do appreciate that. But a lot of these will be addressed in the PowerPoint, so just like stay tuned. So thank you. Okay, so you do have 2 cooling options. You have the air cooling. You also have the dynamic cooling device, also known as the DCD or the spray effect. I'll be honest, I really like DCD a little bit better than air cooling because I find that the DCD makes my job a little bit easier, and I don't have to think about, especially somebody asked here, have you used the shorter pulse durations on the 1064 nanometers? And I have. I treated a very good friend of mine. She's a Fitz in type 6. I did basically full body with the 2 millisecond pulse duration, and I think I did a couple areas with DCD versus a couple of areas with air cooling, and I was fine treating. But I will say, when I'm doing darker Fitzpatrick skin types with the air cooling, I can be a little bit like, oh, I have to hold it here for a second to make sure that it's gotten the skin cold, and then I'll pulse. Whereas with the dynamic cooling device, because it's electronically manipulated within the system and the way that it's delivered, it's a very targeted delivery. So it takes kind of the guesswork out of that. So just some food for thought. I really do like our DCD. I do think the DCD, think of that as your other parameter. Okay, so there are times where I will decrease the DCD based off of the starting recommendations. So for whatever reason, when I treat my dad, he's very sensitive to the DCD. And so at first I was like, is this the fluence? Because I could see a little bit of the footprinting, but he wasn't reporting strong heat. I didn't feel strong heat in the skin after, and I knew I was on really low fluences. So what I did as I got through the treatment was I actually decreased my DCD spray from 40-30, I think, to 30-20, and I stopped kind of seeing that irritation at the skin site. Do you have anything to add to that, Dr. Schallen?
Yeah, I mean, I think that the treatment guidelines are really well written in terms of the fluences. And so if you're under treating and you don't have enough fluence, then you may actually be overcooling. And so remember to really look at the treatment guidelines as a starting point. And then make sure that as you're going along, of course, you're increasing from the baseline starting point by 2 joules until you get to your skin endpoint. And then once you have your perifollicular edema, then that's really the right fluents that you should be putting into the skin in order for it to work. Then the DCD follows after that. So the guidelines for the DCD, you may find you might want to decrease the amount of cooling, the time on tissue, and the amount of elaboration of the DCD, just so that you don't overcool the tissue. But in general, I think that just some minor manipulations from 40-30 to 30-20 are fine with GMPP. I wouldn't go any lower than 30-20 in any patient, though, especially in the larger spot sizes, for sure, because you want to make sure that you're covering well. And let me just take a minute here to say it's really important, I think, at the beginning of every day to make sure that DCD is working properly, right? Do you want to talk about that?
No, go. I mean, all I did was stick the actual cryogen paper on the system.
Yeah, so definitely, take that pulse of DCD every morning and make sure that the nozzle is centered and that you are testing it to make sure that the entire spot is being uniformly covered. That's important. And that's why we always say hold the handpiece flush and perpendicular on the skin, because the DCD has to be laid on the skin evenly. But apart from those two things, you're right. It takes the guesswork out. The device is elaborating the cryogen on the skin for 30 milliseconds or 40 milliseconds, depending on what you choose, which is so fast. And then it's keeping it on the skin to cool the skin for around 20 to 30 milliseconds, and then it's firing the laser. And so it's really, really cooling just the right amount and keeping that epidermis safe on a consistent level, pulse after pulse after pulse. So it provides an enormous level of safety.
And someone's asking here about, should you always use 40-30 on it? I mean, I would love to tell you that there's like a cookie cutter way. And believe me, I legitimately cornered one of our R&D guys and tried to get him to tell me this, but you can't say that, because it's really so dependent on the patient and their reaction and their skin type. All I can really say is if you're seeing unwanted effect, like a little bit of a circular pattern on a lighter Fitzpatrick skin type, and that your fluence is the starting fluences, and those are typically, they're a pretty good starting fluence, less risk adverse starting fluence, then just think about it, think critically, what could I possibly change next, and see what they say. There was also a question about pain tolerance with my dad. When you do men's back hair removal, it's not usually an enjoyable experience for them. It wasn't worse when I decreased the DCD. So just some food for thought there. Okay, so I guess I could have gone to the slide when we were talking about that. But when we're looking at epidermal skin cooling, we have to remember that melanin is in the skin. It's typically located anywhere from 50 to 100 microns below the skin surface. Now, epidermal melanin strongly absorbs visible light, and it can act like a barrier. So what's really important, I did used to get a little bit tripped up on this. So what's really important to remember is that a darker Fitzpatrick skin type has a more dense amount of melanin in their epidermis. And so as you're firing, whatever you're firing, if it's a wavelength that's absorbed by melanin, it's going to start to be absorbed as soon as it hits the skin. And so that can act like a barrier. So the only time you're trying to treat epidermal melanin is when you're treating your benign pigmented lesions in your Fitzpatrick skin types 1 through 3. Your patients that present with a darker Fitzpatrick skin type 4, 5, or 6 have a higher concentration of epidermal melanin. So they are going to be at an increased risk of pigmentary changes. So always treat these patients critically. Am I using a good wavelength? Am I using an effective form of epidermal melanin epidermal cooling? So just something to think about. Where this also becomes really important is when you're doing individual vessels with the YAG. We'll get into that later, but just something to note. Now, what Dr. Schallen was saying is, as you're treating, this is your handpiece. Pretend this is cryogen. The cryogen, as it sprays, needs to cover the entire part of the epidermis it's touching to cool it. A lot of times when you see those, the half moon patterns, that's because usually that's due to not having good contact with the skin. So the cryogen was only covering the part of the skin that it was touching. So that's kind of the way that it works. It sprays, As it evaporates, it brings down the temperature of the epidermis. So as the laser light goes through that, the epidermal temperature is cool enough where it doesn't impact the epidermis by increasing that temperature drastically. Okay, so cryogen spray is made up of tetrafluorourethane, and it has a very high evaporation rate. As it's cooling, it removes heat from the tissue. It is spray. Okay, the other thing to note when you're doing laser hair removal, you typically don't want your post spray enabled. So make sure when you're doing your laser hair removal that just your 2 numbers are activated, which is your pre-spray and your delay. Now, when you're using fluences over 90 joules per centimeter squared, that's when you want to look at using the cryogen spray on the post laser as well. But again, as cryogen evaporates, it removes heat from the tissue. It decreases the temperature of the epidermis, okay? The other thing to note is you really don't want to see the visible frosting on the skin. When you're treating and you're touching the patient, the distance gauge does get kind of sometimes that cryogen spray on the end of the distance gauge. Make sure that you wipe that off before you keep pulsing because you don't want the visible frost on the skin. Unfortunately, too cold also can cause a little bit of a pigment effect. So just some food for thought there. So again, some DCD tips and pearls with darker Fitzpatrick skin types. Extreme temperature should be avoided. Consider decreasing the cryogen spray in the event that you're seeing something you don't necessarily want to see. Remember to consistently remove any cryogen buildup from the end of the distance gauge. And then when this is really important. When switching your hand pieces, make sure you purge the DCD line. So you want to purge the DCD line to make sure that the cryogen is getting through there. So when you switch your hand pieces, and now you're all going to go get your cryogen paper and put it on the device, you pulse it onto that cryogen paper, you make sure that you see that perfect pink circle and you know that your cryogen is effectively making it through the line. Okay, so this is a really good study. So again, this is something that I keep referring back to, but when you're treating with lasers, if you go to Google Scholar and type in you can't say like GentleMax Pro Plus hair removal, but you can type in like 1064 nanometers fine hair, and it will show you kind of the data on that. And the ones that have the little PDF button next to it are going to be available to you. So use Google Scholar. It is very helpful. But when you're performing laser hair removal, you are targeting hair in the anagen phase of growth. The way that I remember that is anagen is active. During the anagen phase of growth, the follicle is still attached to the bulb and bulge. This makes it possible for the heat to hit the shaft, diffuse down to the bulb and the bulge. Permanent hair follicle damage occurs when the stem cells within the bulge reach a temperature of 67 degrees Celsius or higher. So your laser light travels down the shaft, it diffuses into the bulb and bulge, and the bulge is actually where the stem cells are for that follicle. So if the heat hits that and damages that, that's when you'll actually start to see lasting hair removal responses. Okay, so again, this is kind of going over everything. Just remember, there's also a lot of data out there about follicular depth in the skin. So your wavelength is always going to be, is it a Fitzpatrick 4, 5, or 6? Then I'm probably going to use, you should always really, especially with 6s, use your 1064 nanometer wavelength. If it's a Fitzpatrick skin type 1 through 3, you can use the 755 nanometer wavelength. There is a question in here about some of the guidelines regarding using Alex on a lighter Fitzpatrick, a darker Fitzpatrick skin type. That has been done before, but so thus we put it in there, but it just is a lot less risk adverse for you guys to just consider using YAG. So you pick your spot size based off the depth of the follicle. I typically use 18 millimeters. When I treat on the face, I will start to decrease my spot size sometimes. And if it's a new patient and they have a lot of dark, fine hair off the face, like here, let's just say in their back and their legs, I'm going to actually use the 26 millimeters because especially for the first treatment, you'll get a really nice clinical endpoint. And then for your pulse duration, for thicker hair follicles, consider use of a longer pulse duration. For fine hair, consider use of a short pulsation. So one thing that also relates to the thermal relaxation time of the target is what is the volume of the intended target? Finer volume is going to heat up faster. So fine hair is going to hold the heat, is going to absorb the heat. It's going to heat up really fast. And you want the heat to basically heat up really fast and damage the follicle before it can diffuse out, which is why you want to use shorter pulse duration. I like for fluences, if you are on the appropriate pulse duration, then consider increasing your fluence. So again, I kind of rely on my pulse duration more with when I'm figuring out my parameters, and then I adjust the fluence. And then your desired clinical endpoint is a snap and a tingle. Also, you typically want to see perifollicular erythema and edema, or sometimes you don't see that, but the patient will report the rubber band snap. If the patient doesn't feel it, that typically means either the hair is not the appropriate color, or something has to be adjusted with your parameters. Oh, I think this is actually my leg. Yeah. So you can see here, I had a lot of the fine upper leg hair on my upper thighs, and I always do have a hard time treating that in the field. But in a study here that was quoted, hair removal outcomes were evaluated comparing the use of 2 milliseconds versus 20 to 30 milliseconds on fine dark hair. They did feel as though shorter pulse durations outperformed longer pulse durations. In this article, it did state that shorter pulse durations can induce less risk. Be really careful with that. It depends on the Fitzpatrick skin type they were treating, but just some food for thought. Hi, Tina. Someone's asking, is numbing cream necessary? I don't like to numb for hair removal. I really tried to avoid it. What are your thoughts, Dr. Schallen?
Yeah, I think Cryogen does a really nice job for the most part of keeping the patient relatively comfortable. And I agree with you. I never numb large areas for sure. It's not a good idea to, lidocaine can be toxic if you use it in large amounts, or if you use it under occlusion in large areas. So in general, no. There is one exception, and sometimes we do numb in the bikini area. In addition to using the Cryogen, but at that point too, you have to be really cognizant to make sure that you're using the right parameters. So the patient may not be able to give you the same level of feedback. So that's important.
Right. Okay. So somebody asked about using short pulse durations everywhere on the body. It is effective. Let's just start there. But just make sure that, again, you're going off your clinical endpoint. So if the patient has been in the sun, it's probably not a good idea to use the shorter pulse durations, especially on areas that you can see are visibly tan, things like that. It's always going to go back to pulse duration. So although in the study we did do all areas of the face with fine hair with shorter pulse durations, you guys really have to get okay with going off the endpoints. You want to report a snap and a tingle. You want to make sure that you ideally see the PFEs, or if you don't see the PFEs, they are reporting the snap and a tingle. There's a question here about what pulse duration would you recommend for a man's scalp? I typically start at 10 or 20 milliseconds. Do you agree, Dr. Schallen?
Yeah, again, it's about the thickness of the target. And so if you've got really thick hair, then you may want to lengthen it out to 20 milliseconds. But in general, I think 10 milliseconds is okay. Remember, GentleMax was, the Gentle family had 3 millisecond pulse durations for 15 years and did very, very well. So in general, your 3 millisecond pulse duration is going to do a very good job. But it's with the thicker hair, with the darker skin, that sometimes you want to lengthen that pulse duration so that you're really optimally treating the larger targets. And with the fine hair, it's nice to be able to have the 2 millisecond pulse duration.
Yeah. And then Cody, hi, we have a question here. Do you treat people who have been in the sun? I really don't no, especially not with the Alex. I really ideally want them out of the sun for a minimum of 2 weeks pre and a minimum of 2 weeks post. I just ended up going on the internet and finding a photo of footprinting, and then I show the patient, because for some reason there seems to be this inability to recognize how much recent sun exposure people have had. So I will show them the photo and say, like, if you've been in the sun, or if I'm, you know, this is what is potentially going to happen. So that is a thing. Okay, so oh God. We have a patient here who is on hormone medication, and they are in the process of transitioning. She is now completely unable to tolerate, oh, I'm sorry, and sobs through every single treatment, even with tack cream. I see this in several of our transitioning clients. Do hormone medications make that big of a difference as far as pain tolerance? I don't know that that's ever been studied, but anecdotally, I can tell you I did treat a very similar situation in San Diego, and yes, I did see that. And I know for me personally, when I'm getting my period and my hormones are changing, I, you know, am a little bit more sensitive to those things. So I do think there is some of that. I think with those clients, you know, typically it's going to be more sessions with lower fluences.
You have to make sure, though, that those fluences are optimal.
Right, right. So I guess in Meredith, in that case, if you have the chiller, you can try using the chiller, or they could like put the ice on really quick and take it off so that it doesn't get super deep into the dermis. I don't know how else you can really try to control that pain.
No, I think it's
okay. Okay, so here you can see we talked about this a little bit, but we talked about paradoxical hypertrichosis. Make sure you're treating to clinical endpoint, and make sure that you're cooling the area around. Now, what I'll do is if I do someone that I'm concerned with this, I will, sometimes I'll do a second pass if I cool the area and go. Marissa, I think this talk will be available for you to do what you're asking us to do again. So just in the efforts of time, you can rewatch the recording and record that so you can show it to your boss. Okay, so this is just showing you a slide about how larger spot sizes decrease your time in the treatment room, thus increasing your revenue. I love the larger spot size. I highly recommend it. You're able to fit in more clients, and you know, in some cases you get through the treatment faster and they can just tolerate it a little bit better. This is also showing you, this is a really cool slide. So you can get through a lot more patients, 9 more patients a day. If you have the 26 millimeter spot, you can get through 7 more a day with the 24 millimeter spot, 5 with the 22 millimeter, and 3 with the 20 millimeter.
And I just want to stop and say, you know, at a normal practice, you may not be trying to just get patients through, but one of the big advantages of those larger spot sizes is it is more comfortable for the patient because there's fewer pulses. Patients do find those larger spot sizes a little bit more comfortable. And now that we have the extra fluence on those larger spot sizes, it's extremely effective. I mean, we're really seeing that PFE at 26 millimeters, which is penetrating well, which has a large effective fluence. So I think that we're having more effective hair removal at 24 and 26 millimeters than we ever were able to before GMPP.
Right. Okay. Okay, so this is someone that I treated at the Candela Clinic. You can see here, even with 2 joules lower, you can still see that there's a strong clinical endpoint. This says axilla. I apologize. It was the back of a neck. But you can see here that I still had a really nice endpoint. And I just thought that was a very interesting slide, especially for me. Like, I like seeing those endpoints. So and he's a light Fitzpatrick skin type. So this degree of erythema is expected. Okay. Or well, can happen. Okay. So let's talk about vascular lesions. Okay. So
Before we go on,
yeah.
Do you mind if we answer a few hair removal questions before we move over to vascular?
Yeah. So Dr. Schallen, in theory, I don't like to treat people who have recently been exposed to the sun because their melanocytes are aggravated. You're going in and putting more heat, and there can be an increased risk of hyperpigmentation. I really don't like to treat anyone who's been in the sun for 2 weeks on the face or 4 weeks on the body. Do you agree? What are your thoughts?
No, I absolutely agree. And that's where really why I wanted to stop and answer a few more of these questions, because there was a question in here about, what's the time duration? And I think it's so important to remember that when people are tan, their melanocytes are really revved up. They're really going to hold that pigment for quite some time, even beyond this active tanning period. So even that passive tan can months later, if you use the 755 nanometer wavelength, still be problematic because you've got a lot more melanin in the skin than you did. So say, for example, you're treating in October and the patient was last on the beach in August, but spent all of August on the beach. Well, you really have to be careful. It's beyond that 4-week time period, but that patient still is highly susceptible to a burn, especially if you go back to the parameters that you were using before the patient went on vacation in August. So that's important. And that's why, again, it's really helpful in the summer months to be able to switch to the Nd:YAG. So when you're out of that active tan phase, it may be better to slowly get the patient back on track using the Nd:YAG before you go back to the Alexandrite, which is another reason why I like using this device, because it gives you those options of using Nd:YAG even for your lighter skin patients. So super important there. And then another question here is there's still some confusion about when do you use which pulse duration. So when would you use a 10 millisecond, a 5 millisecond, and a 3 millisecond? What would you say, Meg?
10 milliseconds I typically use when the hair is thicker, or okay, guys, one thing I've learned is you kind of have to, when you're evaluating your client, it's really important to evaluate the client's ability to follow pre and post care instructions. So if I think that there's a potential where they're not going to be the most compliant patient, I tend to use my 10 millisecond pulse duration just for that little added zone of potential comfort. So thicker hair would be 10, moderate hair would be 5, fine hair would be 3, fine facial hair would be 2. Mm-hmm. Any thoughts? Or like my leg hair that you saw earlier, that was very fine hair. That would be a 2 millisecond.
Yeah. Fine, and then 3 milliseconds, I think, is really pretty versatile. So, your normal hair that's not thick is going to respond pretty well to 3 milliseconds. What about rep rates? I think we should stop and talk about rep rates for a second here too. There's a question about what speed do you normally use? What do you think?
The fastest typically that it will allow me to, but I don't always do that on my darker Fitzpatrick. On my darker Fitzpatrick in the first session, I'm usually hovering 1 to 1.5 or 2, just because I don't want the overlap. Rep rate is something that's almost like an 8th, 7th parameter, 6th parameter, because if you have it really depends too on your ability to maintain an appropriate overlap. So if you're like the Olympic rings with the 10 to 20% overlap, you have the ability to use the higher rep rate. If you're new and you're starting out and you're a little like you don't feel super comfortable, consider using a lower rep rate.
And also on the curved areas of the body. So, I find that we see adverse events come in, and when we see them come in, it's often on the curve of the body because they, a user has not kept the distance gauge flush and perpendicular to the skin. So if you're doing a 2 hertz or higher rep rate, it's hard to kind of keep that keep doing that, especially in the curved areas of the body. And then I have a rule in my office, and that's on the face. We don't go to 2 hertz. I really think that it's important to stop and be a little bit more deliberate on the face and go a little bit more slowly. But you're right. A lot of it depends on how much hair you do and how mindful you are when you're doing it to make sure that you're flush and perpendicular and watching the skin response. And
Yep. Okay. So quickly, how does one treat hormonal facial hair? I kind of tell my hormonal clients or patients that I suspect have some kind of hormonal situation based off of the, signs and symptoms of, let's just say, PCOS is, we can definitely get the hair growth to visibly look a lot better, but until your hormones stabilize, just note that, you're going to need maintenance sessions typically more frequently than if the hormones were completely stable. Do you agree, Dr. Schallen?
Right. And same thing that we say, right, to patients just post-pregnancy or younger patients who come in wanting hair removal, that they're still going to have a lot more hair growth because their hormones aren't stabilized. So, and for PCOS, for example, it's important to treat the underlying condition to get your best hair removal result. So until the hormones are stabilized, you won't get that maximal clearance.
Right.
Sometimes that's not possible.
Right. Now, yes, Elizabeth, you should always drop your joules with whatever system you're using. When you decrease your pulse duration, always consider always decrease your starting fluence. Now for test spotting, Kira, it kind of depends on the skin type. So Fitzpatrick skin types 1 through 3, I'll typically wait 15 minutes to a half hour. If I do think I have some underlying thought that they've been in the sun based off of their appearance, I actually will make them go home and come back the next day. And then for your darker Fitzpatrick skin types, I have seen, remember that one case we had at the clinic, like 4 or 5 days later with some of the pigmentary changes? Do you remember that, Dr. Schallen?
Mm-hmm.
It was like forever ago. Then if I do darker Fitzpatrick, the longer the better. So if you could wait a week post, that would be great.
Yes, test spots for sure. We haven't talked about test spots too much, but test spots are super important, especially for darker skin types, and up to a week, really. Post-inflammatory hyperpigmentation takes some time and in some cases to present itself. There's a question, do you treat around freckles or just moles? And that's a great point. Definitely. There's these great little stickers you can buy, or you can white over the mole, but white pencil alone is not enough. So be careful to treat around. And if it's a freckle, that can, it depends on whether it's eumelanin or pheomelanin. And there's, you will have some response to the freckle, or, and so if a patient really, really likes their freckle, then you better avoid it so that you don't get rid of it.
Right. Okay. So there is a question here about how you treat the upper lip because of DCD going into the nose. I mean, I would just, I actually haven't really heard that, but if you are concerned, you can just push the nose or block the nose for a second, have them take a deep breath, and which is what I do sometimes for pain anyways. You could just kind of hold and pulse there.
Yeah, there's really no issue there.
Yeah.
Okay. Yeah.
Okay. Okay. So if you guys wanted to block an area, like let's say you're treating the upper lip and you want to block the area, you can use a wet tongue blade. That's fine. Or a wet white gauze will get in the way. A tongue depressor helps. Thank you. Somebody said if you're worrying about the DCD in the nose. Hi, Maribel. If you need to order anything, you can just utilize our e-store or Candela portal. Okay. I am going to keep going here. Yeah. Well, this is kind of a nice question. As 759 5 nanometers targets melanin and 1064 targets water, can we make the second pass with 1064 after the 755? You can in your lighter Fitzpatrick skin types, and when you make sure, like, touch the skin a lot. If you feel a lot of heat, don't do a second pulse or pass with anything. But if you don't feel that, it's a lighter Fitzpatrick skin type, as Dr. Schallen referred to earlier, it is okay to use a second pass with a second wavelength. And then just really quick, Dr. Schallen, I am interested to hear your answer to this too, and then we'll move on to vascular. In your experience, do you continue to treat patients with, I actually don't feel like I see paradoxical hypertrichosis that much now that I cool around. Do you feel the same way?
Same way.
Okay. Okay. And you would continue to treat your paradoxical hypertrichosis with that. If you're seeing the result, you would continue to treat them. Well, I guess you don't see it.
Yeah, if you develop paradoxical hypertrichosis, you now have to treat that hair, which is difficult to treat because it's usually very fine, and you probably need to drop to 2 milliseconds. But right. Yeah, is that your question?
Yeah, perfect. Thank you. Okay, so let's move on to vascular. So it's you're typically using your 1064 nanometers. In some cases with resistant lesions, you can use the 755 nanometers. Basically, it's going to target the oxyhemoglobin and deoxyhemoglobin. The oxyhemoglobin or deoxyhemoglobin absorbs that laser light, and just think of that as what's inside the blood vessel. So it absorbs the laser light, it converts it to heat. The heat diffuses from the inside of the vessel to the vessel wall. It's going to then damage the vessel and collapse upon itself. Your vessel will be reabsorbed by the body over several weeks to months, and you should have your effect. Now, a couple of things. I do consider individual telangiectasias an advanced modality. So, you know, if you're going to do this, make sure that you and your medical director are really involved. You have a great relationship with them. Always skip at least one spot size between each pulse so that you don't effectively have twice the energy delivery in a spot. And using shorter pulse durations on individual telangiectasias can increase the risk of rupturing the vessel, so bruising versus slowly coagulating. Now, when you're doing leg veins, if you cause a bruise, a lot of times that bruise is at an increased risk of causing hemosiderin staining, which is basically just kind of a pigment change that you'll see in relation to iron deposition on the skin. So, I really do consider leg veins an advanced modality. Ideally, they've been evaluated by a vascular and they've had some kind of ultrasound prior. A couple of things that I learned is you want to ask the patient, do your legs swell in the summer? Do they ever hurt when you're on them for long periods of times? These can all be signs of venous insufficiency. And so I typically actually won't treat those patients unless they have some kind of ultrasound prior to treatment. So just some food for thought. When you're treating individual vessels on the face, never go above 1.5 millimeter spot size. If you're treating leg vessels, you can use the 3 millimeter spot size. But again, bluer, thicker lesions are going to need the bigger spot size because they'll need the deeper depth of penetration. Okay, so now we're getting into benign pigmented lesions. Hi, we do have a question from Raylene about how, after treating spider veins, how long can that brown discoloration last?
So that hemosiderin that's in the skin can last for a year or more in some cases. And if there's UV radiation, in other words, if the patient goes out into the sun, then that stain can last even longer than that. So it's important to make sure that patients are not sun exposed, that they're also following the right pre and post instructions in terms of making sure that they're not taking blood thinners or anything that could work like a blood thinner, that they come in afterwards with their compression stockings. So there's a whole host of things here that we won't cover in detail, but that you definitely want to learn about and read about, and that we have materials specifically created for in terms of treatment of vascular lesions. But you want to make sure that you're trying to avoid that to minimize the risk of post-inflammatory hyperpigmentation with vascular treatment. But you're not going to be able to eliminate the risk. It is something that is part and parcel of treating veins, whether it's with sclerotherapy or with laser.
Yeah. Okay. So Dr. Schallen, just real quick, if somebody does see hemosiderin staining, it might just be like topical tretinoin or what, how do you feel? What do you?
Some people find that that's useful, but for me, the most important thing is to just leave things alone until the skin is completely healed. And then you can consider a variety of different things. You can, picosecond laser can work at times for post-inflammatory hyperpigmentation and hemosiderin deposition. Sometimes you can have some topical bleaching agents that will help. But if it's deep and it's hemosiderin, it's sometimes quite difficult, and it's a matter of time.
Okay, so now we're going to transition into, yes, Stephanie, that's a good point. A pico, potentially anecdotally speaking, this client is feeling as though they get good results with a pico pulse duration. Some food for thought. Okay, so now we're going to go to pigment. So when we're talking about benign pigmented lesions, we are targeting the melanosome within the keratinocyte. So you can see here, this lovely dendritic looking cell with the octopus arms is your melanocyte. Your melanocyte sits at your DEJ. When you go into the sun, your body produces melanin. the melanocyte packages up the melanin into a melanosome, and then it pushes it through its dendrite to the keratinocyte. And then the keratinocyte is actually the cell that will move to the top layer of the skin with the melanosome component in there. So so one thing to note, when you're treating benign pigmented lesions, you're not stopping the patient's ability to produce pigment, because if we were doing that, we would have hypopigmentation, which we really don't want. We are treating what's visibly there. So it's really important when you're treating your benign pigmented lesion patients. And, you know, this is a great treatment for patients that are really freckly. I see a lot of women that honestly could probably GMP plus their entire body for pigment. So this is a great treatment because you don't need to use gel. You can hover again, you know, you can get through a larger area quickly. But if the patient goes back into the sun, those brown spots are either going to come back or they'll produce new ones. So you really want to make sure that for these patients, they invest in some kind of SPF shirt if you're doing it off face, and that they're using a physical UV sunblock. A broad spectrum physical sunblock of an SPF of 30 or higher is ideal. That there is some data that shows that you have to reapply your SPF 80 minutes or 60 minutes when wet. So something to note with that. The other thing that I've noticed is when they get a spray tan, like there's a patient, I think she's in this PowerPoint, who had the most amazing results ever. And when I brought her back in for her 3-month follow-up, some of her brown spots had come back, and she's not really a sun person, but she did have a spray tan. So there is I do think there's some melanocytic excitation, I guess, when you get a spray tan. So just some food for thought when you're treating these patients. Now, when you're treating benign pigmented lesions with the laser, you really have to make sure that they're out of the sun, because this is when, you know, when you're hovering over the tissue and you're trying to hit the epidermis, you're more superficial in the tissue. So if they have aggravated melanocytes, that can be, you know, not ideal. So when I treat my benign pigmented lesions, I don't have DCD on. When I don't have DCD on, I will hover over the tissue. Now, if I'm treating isolated lesions, like I have some on my upper arm, I'll use a wet white eyeliner or a wet white gauze. I'll cut the middle of it and, you know, make sure that the surrounding area is covered. And then I'll hover. And then when you're treating benign pigmented lesions on face, it's 3 sessions are recommended, spaced at 4 to 6 week intervals. And for your patients that are prone to freckling, they're going to need maintenance treatments, typically once or twice a year thereafter. If you're treating pigment off the face, up to 3 sessions are recommending, occurring at 6 to 8 or maybe even 10-week intervals. For your patients that tend to run a little bit dry post-treatment, like I did someone's arms recently, and they messaged saying it was like 6 weeks out and the pigment still hadn't like flaked off. Have them just increase their hydration. By increasing their hydration, and this is something Dr. Schallen taught me, I will say that, honestly, you did. The more hydrated the skin is, the faster the cell turnover. So they need to keep the skin really hydrated post-treatment. I had her just go and buy, it was like 6 weeks post, so I just had her go and buy the Vaseline body spray, and she did, and she said it was wonderful. So just some food for thought. Oh, this is the patient I was talking about. So you can see here at 6 weeks, the results are like great. But then at her 3-month follow-up, unfortunately, she had a spray tan the week before. So some of them had come back, but a great treatment to do. It's really great. Okay. So now we're moving to 1064 nanometers wrinkle reduction. Sorry, I just need to keep going here. So with 1064 nanometer wrinkle reduction, now, so typically our dermal matrix is made up of type 1 and type 3 collagen, along with elastin fibers and glycosaminoglycans. As we age, our type 3 collagen changes from a mixture to mainly type 1 collagen. So to address skin aging, one important component of it is to try to address collagen and stimulate collagen. The other thing that, you know, we're still working on is this elastin component. So the ability of your skin to kind of snap back does change as well. So now with the 1064 nanometer wrinkle reduction, you're going to deliver the energy in a non-ablative manner, leaving the epidermis intact. It's going to be absorbed by the water within our skin. Now you can perform multiple passes with either a short pulse duration. So that's when you hover and you use the drop down screen on the GentleMax. You're going to, the way that you do this when you're hovering with low energy, I really only treat from here to here with this. I don't think the benefit outweighs the risk up near the eyes. And that is just how I think. So anyway, so when I'm treating, I'm going to divide my area when I'm hovering into business card size area. I treat each business card size area until I get it to a minimum of 40 to 43 degrees Celsius. And then I try to maintain for as many passes as I can, but no longer typically than 1 to 2 minutes. The other way you can do that is stamping, and we'll get into that in a second. But basically, when you're doing this, you're causing dermal heating 1 to 2 millimeters below the skin surface. Now, in the study that is cited here, they felt that they saw final results as soon as 5 weeks post-treatment. Maintenance must be performed quarterly to biannually. And what was kind of interesting was at 5 weeks, they thought they saw increased levels of both type 1 and type 3 collagen, as well as the collagen fibers going from disorganized to more organized. Now, what's also interesting here, and we don't have the indication for any of this, but this was something that they saw clinically in their study. They did see an improvement in pores. They felt as though they did see a visible decrease of skin wrinkling and an improvement in skin texture. So I do feel as though this is a great treatment to offer. I love it, like after Matrix Pro, like let's say you've got, or even Profound, let's say their jawline has had this really nice increased definition. You can see the gonal angle. You have this really nice effect on the jawline. I would try to maintain this with this treatment. So what's great about this treatment is it's kind of a red carpet treatment. So you really do feel great after the treatment. You just feel like your skin looks so healthy. And it also is going to have no downtime. So this is kind of how we did this. The first method, we used a longer pulse duration and delivered the energy in a stamping pattern. So I would treat from here to here, 1064 nanometers, 15 millimeters, 20 to 24 joules, and the DCD was at 2010, and I did this 3 times. Now, if it's a darker Fitzpatrick skin type, you're going to want to consider doing one or the other way for the first session, and then maybe adding on to doing both ways at the second. But always kind of look at your skin reaction. You want to see uniform erythema, and you want to see it uniform. You don't want to see like footprints with that. And then the second half of the treatment that we did at the clinic, I think we did like 10 patients with this. We hovered with 1064 nanometers, 10 millimeters, 8 to 10 joules. DCD was off. We separated it into business card size area. I would treat a business card size area. I get it to temperature and try to hold it for, I said 5 minutes. I've never actually gotten anyone to 5 minutes per vector, probably more like 1 minute. So just some food for thought with that. Dr. Schallen, is there anything you wanted to add there?
No, you're right. It's really bulk heating. So keeping that small area for 5 minutes is really impossible. You really have to get that to temperature, usually using an external thermal temperature. You can check too, and then just move to the adjacent area and then keep that whole zone maintained by temperature. But you won't be able to use that really small area for 5 minutes.
And so this is a patient, you can see she had a nice kind of definition of her jawline. So you can see that, you know, her jawline does look quite nicely improved. And that was a month, it might have even been 8 weeks after 4 treatments. So this is a really nice treatment to, you know, I do tell the clients it's going to improve the quality of your skin. It's a great treatment if you don't want downtime. It's a great treatment for your younger Fitzpatrick or your younger patients. And I do think it's kind of a nice way. I'm getting a lot of jawline requests, you know, and although filler can make the appearance of a tighter jawline. It's really not doing anything to address the overall skin health. And if they're not down for a profound or a profound matrix, which is the RF microneedling yet, then this is a great option to start them and kind of dip their toes in the water until they're ready for the more advanced modalities. Okay, so in this patient, I was like, oh, this is a great patient to try to do a combination treatment with. So what I did with this patient, you can see she has a lot of diffuse pigment. I did the diffuse pigmentation with the Alex first. I think I was at, actually it's in this video. So, and then I did the 1064 treatment, the way that I had the parameters written on that slide before. So I did the stamping first, and then I hovered. And we'll get into that here, but this was technically the treatment protocol. So 15 or 18 millimeters, 12 to 16 joules. This is for pigment, no cooling. Then I did cool after this because, again, as Dr. Schallen has taught me, when you're treating pigment, you don't really need the heat to sit there very long. So I cooled the patient before I did the next step. So I used some ice packs, I used ice packs. I got the skin temperature down a little bit. I took the ice packs off. I waited for the temperature to kind of come back to baseline, and I kept touching to make sure I didn't feel excessive heat. I also kept making sure I didn't see any of that footprinting that we were talking about earlier. And then I did the stamping technique, and then I did the hovering technique. And there's actually a video on this. So let's get into that. And I was also treating her face with the 1550 frac, so that is why she has some numbing cream on. Okay, so here is our treatment that we're doing. So you can see here, I just used the drop down solar lentiginous. She was I will Fitzpatrick skin type the chest a little bit higher. This is my future mother-in-law, and she really is like a skin type 2, but I always will add to a 3. And you can see here, I pulse once. Now see how immediately that your endpoint when you're treating is darkening of the pigment. So you can see how the pigmented lesion darkened, but you don't see the footprinting pattern around the skin. You don't see kind of a red circle. So, oh, we cut that a little bit fast, sorry, but basically I hovered over, I think we're just showing my parameter selection here. So then with the 1064 nanometer, this is how, and you can see here I'm stamping. So that's using the stamping technique on the 1064 nanometer. Now this is going to be a little bit of an aggressive energy delivery when you're combining it the way that we are. So just note that the patient is going to feel this. I did apply topical numbing to her chest, and then I wiped it off. So you can see here, you want to see uniform erythema when you're performing these treatments. And then I hovered. Now, when I'm hovering, I'm treating each business card size area to 40 to 43 degrees. I measure it off of the thermogun. Once I reach that, I try to do additional passes for about up to a minute, but realistically, it's probably only 4 or 5 passes per vector, and then I move to the next area. People really do like this treatment, so just some food for thought. Dr. Schallen, do you have anything that you'd like to add there?
No, I think that this is really great, and it helps us kind of take advantage of all the different modalities of the GMPP. You know, you get to use both. You can use both wavelengths, the 755 and the 1064, short pulse durations, longer pulse durations, and I think that many of you may have heard of techniques around the world that kind of just take advantage of using all of these in all these wavelengths and all of these different ways of using these wavelengths to do things to generally rejuvenate the skin, to take care of browns, to take care of reds, to improve the texture, to help with wrinkle reduction and create collagen and just overall have a more rejuvenated appearance. So I think it's a wonderful way to do that.
Yeah. So there is a question in here about what parameters I had used on that patient's arm. It was 18 millimeters, 3 milliseconds, and I think by her second treatment, I had gotten up to 18 joules. I typically start at 16 joules, but I may do up to 2 passes. that patient is a very fair fits. I mean, she's like an ideal client. So, you know, I had some wiggle room because the contrast between the brown spots and her overall skin was significant. But again, it's really based off of endpoint. And so if you're doing a benign pigmented lesion, and let's say you're like, you know, one good thing you guys can consider if you're starting to look at doing these treatments is there's a whole clinical workbook that I actually worked on when at the clinic that kind of goes into all of this. But one thing you have to remember when you're treating benign pigmented lesions is, again, it's based off of endpoint. So you want to see a darkening of the lesion without seeing the surrounding area get super red. If you're doing, and so let's say you're deciding that you want to incorporate this into your practice, you could consider bringing in patients for a test spot day, do a couple of test spots, and then wait a couple of days or up to a week, bring them back in, make sure you don't see anything, and then do the full treatments. You could offer them a reduced cost, and then you can kind of generate your before and after marketing photos. There's a lot of data on our portal about all of this, and there's quite a few treatment videos with that. Again, you'll also have access to this PowerPoint after we complete this, so you can look through where it outlines the parameters, and you can also rewatch some of the videos.
Yeah, definitely. Don't think about settings concretely. It's really all about endpoint. And with your 18 millimeter 2 hertz painting technique, it really depends on how close you are to the skin as well. So we recommend being a centimeter above the skin, but that's really close. And I know I feel a little uncomfortable going that close. So I hover at about 2 centimeters. So, you know, maybe I can have a little bit higher fluence if I do that. But if I'm somebody who really gets close to the skin, I'm going to really want to be using lower fluences. So don't look at the fluence concretely. Think about what's happening to the skin, the endpoint that you're seeing, the darkening of the pigment. You don't want to see a lot of erythema on the adjacent skin. You're going to get some. You have to think about this in terms of your Fitzpatrick skin type and any sun exposure too. So it's just kind of all of those things all at once. And like Meghan says, there's so many materials. It's a lot of information. We've got a ton of questions. Depending on where you are and in all of these treatments, there's start from the beginning and slowly go through all of our materials that you can listen to over and over again with regards to laser physics and laser tissue interaction, and really kind of understanding what all the parameters mean. And you'll feel much more comfortable about all this.
And then, okay, so a couple questions for post-care with wrinkle reduction. So kind of think about this from this perspective. We're not breaking the stratum corneum. So you can kind of use at your discretion what your medical director agrees with. The argument could be, do you need to use, you know, something? Not necessarily. It's a nice add-on. I know I really like elastin nectar, just post-procedure, really anything, but is that necessary? Probably not. The one thing I will say that I feel is necessary is sunscreen, because these patients still have a little bit of heat in their skin and now they're leaving your clinic. You do want to make sure whatever you use does not kind of affect the collagen stimulation ability, you know, so just something to think about. And then we have a question here about if you treat someone, let's say they've done a profound, how long would you wait? I would say 2 months, but what are your thoughts on that, Dr. Schallen?
If you've done a profound treatment, I would really wait a full 4 to 6 months to begin these treatments, because, you know, you're really generating collagen here with the profound treatment. And I wouldn't impact that. I would let the treatment run its course and really fair. understand what the treatment can do for you. You can try other combination things that maybe aren't doing this similar things at the same level. So I probably wouldn't do YAG immediately after profound, not that soon.
Okay, perfect. Now, Dr. Schallen, we do have a question about, can this be done on the abdomen? I mean, there is some data on that for sure. I do find if you are trying to treat someone who has had a baby and they have that post delivery or postpartum skin laxity, sometimes I do think you need a little bit more of an invasive technique, but you can.
Yeah, I mean, this is a nice technique, but you're bulk heating, so you're getting to temperatures that are lower temperatures. This is very different from something that's raising temperature. You're not raising temperatures to from 62 to 72 degrees centigrade. You're really in the under 45-degree range. And so it's a different type of collagen stimulation. And it depends on, it's great for skin health. It does a really nice job with wrinkles. That's why it's cleared for wrinkles. But it depends on what you're trying to achieve with the abdomen. If you're really trying to achieve something more significant, then that's for a different level of temperature.
Right. So there is a question regarding how do I know when I need to do a second pass with the benign pigmented lesions? It's just if I don't see my endpoint. If I have a lighter Fitzpatrick skin type and I'm not seeing darkening of the lesion, then I will do the second pass once I've cooled. I do touch a lot. Like I'm always touching. Like, do I feel a lot of heat here? What's really going on? So you really have to, you're looking for darkening of the lesion and you're making sure you're not feeling a lot of heat. If you don't see darkening of the lesion and you don't feel a lot of heat, then it may be okay to do a second pass after you've cooled. And then there's a question here about doing the 755 nanometers first and then the YAG. I would be a little, I don't love that idea because the 755 is so absorbed by melanin and you're going in and you're already having heat in the skin. I would just always try to do it the way that I've done it. Do you have any thoughts on that, Dr. Schallen?
Is the question, and I'm sorry, I don't see that question, but
they're asking, could you do YAG first and then Alex?
You're going to bulk heat, and it depends on what you're targeting. If you're just going to then do Alex on the pigment, on discrete pigment, it's probably not going to make a huge difference as long as you're cooling in between. But if you're going to then do a painting technique with your Alex, you will have bulk heated underneath as well, and you probably would have made the tissue a little bit of erythematous also. So, I agree. I would try the 755 first and treat the pigmentation, cool, and then bulk heat with the YAG.
Perfect. And then we just have, we have time for one more question. So someone's asking, with the stamping technique for the wrinkle treatment, do you need to overlap as much as with hair removal or does it not matter? I still overlap about 10% just for coverage purposes. Do you agree? Do you feel differently, Dr. Schallen?
I don't feel too strongly because you are bulk heating, but I think what you don't want to do is overlap. So, your DCD is turned off for the majority of these stamping techniques. There are some stamping techniques where you have some mild DCD, but really all you're trying to do is apply heat to the skin, and you just don't want to overdo the overlapping.
Right. Okay, everyone. Well, thank you so much for your time.